Let me know if there's any issues with volume, if I need to speak louder, things like that. Okay, so let's get started. We're talking about the esophagus today. It's the score year 2. So the way that we're going to sort of break things down, if you think about the topics from sort of inside out of the esophagus, intraluminal, mucosa, submucosa, and full thickness topics. Year 1 is like ingestion, forebody, all this stuff, cancers, diverticula. Year 2 is all about what we'll talk about today: strictures, GERD, Barrett's, motility issues, and hiatal hernias. So this is sort of our outline of the things we're going to talk about today. Okay? So starting off, the esophageal structures. It starts essentially up at the upper esophageal sphincter, and it goes down to the lower esophageal sphincter, and these are sort of the distances, these are the lengths that we measure from the incisors. So upper esophageal is from 15 centimeters, you go down to sternal notch, that's 20, where the esophagus and the pulmonary vein crossover, that's 30, and then the lower esophageal sphincter is 40 centimeters. Arterial supply depends on where you are in the esophagus. So high up in the esophagus, it's supplied by the inferior thyroid. Mid-esophagus are branches, direct branches from the thoracic aorta. And then the lower esophagus is from the left gastric and inferior phrenic. The inferior phrenic is not labeled on this diagram. Venous drainage is from the esophagus on the patient's right side, hemiesophagus on the left side. There's also accessory esophagus and accessory hemiesophagus. There's an actually area where it'll junction off. In terms of the histology and the layers, it's the same as all of the other intestinal layers that we talk about: epithelia, lamina propria, muscularis submucosa, and muscularis propria. But esophagus does not have serosa. It's a very commonly tested question. Does not have serosa. This is what the actual high-powered histology looks like. You could see, you know, epithelium, mucosa, submucosa, all that stuff. When it comes to the muscles, we all just have to remember that there are 2 different types of muscles in the esophagus, and it changes from each third, the composition of how much is skeletal or striated muscle versus how much is smooth muscle. And we remember that skeletal muscle is voluntary, smooth muscle is not. So skeletal muscle, you know, all our sort of upper esophageal sphincter or swallowing mechanism, that's all skeletal muscle, striated muscle, whereas lower down where peristalsis, that's not voluntary, that's smooth muscle. That's the way I like to sort of remember it. So there's also different, the fibers go in different directions. So the inner layer is circular, so that's the muscularis, what is that, the mucosa, and then muscularis propria is the longitudinal layer. This is, you remember that there are different nerve plexes within the esophagus. There's Auerbach's plexus and Meissner's plexus, and those are all in the different layers. Maybe it's worth memorizing which layers they are, maybe not. And again, this is just a diagram from Netter showing that, you know, at the upper third versus the lower third versus the middle third, you just have different compositions of muscle. Innervation of the esophagus, it's just really easy if you remember this mnemonic LARP, L-A-R-P, so left anterior, right posterior. That's just how I remember it, and I've never forgotten it. I don't know why that works for me. What's important to know is that the right vagus gives rise to the celiac plexus and the criminal nerve grossi. That's sort of like I guess a flashcard question, or like a Pfizer question. I haven't really seen any practice questions asking about that, but it is useful to know this LARP mnemonic. In terms of the actual epithelial layers, in the mucosa, it's mostly stratified squamous epithelium in the esophagus. And then at the GE junction, that's where it changes over to columnar cells. The Z line, as described here and drawn here, is where that transition occurs. And that's where anatomically the transition from esophagus to stomach is. But There's certain pathologies that can obviously change that, like Barrett's and reflux and things that we'll talk about. But essentially, this is sort of more like a high-powered view that you can sort of see the columnar cells down here transition in this spring cell. So this is called the transition zone, or Z line specifically here. There are other transition zones in different parts of the body. This is important one. This is what essentially Barrett's kind of looks like. You can see the transition of columnar cells to stratified squamous cells. And this is another picture of Barrett's. So the upper esophageal sphincter, it is actually a true sphincter because it actually constricts, and it's actually under control of striated muscle. So it's made up of the cricopharyngeus, the thyropharyngeus, and the inferior pharyngeal constrictor muscles, right? So the idea of the upper esophageal sphincter is that it prevents air swallowing and it prevents reflux of esophageal contents into the pharynx, right? At rest, it's contracted. And it's at like 60 millimeters of mercury at rest. So that prevents air swallowing. When you swallow, that pressure goes down to allow food and boluses of liquid or whatever to pass through, right? Whereas the lower esophageal sphincter is not a true sphincter. It's essentially just extra tissue. You can think of it that way. It's a lot more complicated now. Lower esophageal sphincter is actually quite complicated, but it's not technically a sphincter muscle, right? It's a high pressure zone at the GE junction. It's not necessarily visible on endoscopy nor laparoscopy. It's essentially this functional area in the lower esophagus. Most of it, occurs at the GE junction, and then 10% is from the crura. At rest, it's contracted to 15 millimeters of mercury to prevent reflux from gastric contents up in the esophagus. And then once you swallow, that pressure goes down to 0. It's vaguely innervated, and obviously it relaxes during swallowing, belching, and vomiting. So the lower esophageal sphincter, what is it actually made of if it's not a true sphincter? So essentially, the distal esophageal muscles, they're actually tonically contracted at baseline. So that's going to provide you a base level of increased pressure. Then there are sort of muscular sling fibers from the gastrocardia that adds to that structure and contraction. The crura are a really important part of the sphincter and then to maintain that pressure. Obviously, we will talk about hiatal hernia later, so that's really important. And then the transmitted pressure of the abdominal cavity, that presses up on this hiatus in this area of the sphincter, and that's what also helps maintain sort of this sphincter zone, this lower esophageal sphincter, to prevent reflux. So we will go over some review questions. I am going to start with Serge Onk. So Serge Onk, can you unmute yourselves? And we're going to go through the first question. I am not hearing anything. Okay, Sir Doc's having trouble with their audio. We will go in reverse order. Team 5. Okay, so esophagus is no cirrhosis. Team 5. Next question. Muscularis propria transitions from what to what type of muscle?
Skeletal to smooth.
All right, good. Straighted. Okay, next.
Blood supply to the esophagus is segmental. Cervical is inferior thyroid. Thoracic is branches off the aorta. Abdominal is the left gastric and the inferior phrenic.
Good. Innervation.
vagus nerve. The left tracks anteriorly and the right is posterior.
Yeah. And what is the total length of the esophagus?
I'm sorry, what's the question?
Esophagus is how many centimeters long as measured from the incisors?
It's gonna be different people, I guess, like
40?
40 is a good estimate. Right, good. Thank you, guys. So we are going to talk about GERD. We talk about reflux. So we all sort of know what reflux is. Everyone has a little bit of reflux, and it's usually short-lived. It's only pathological when it has symptoms and you have complications. The formal definition of reflux is a little bit controversial, but you can think of it that way. 20% of patients with reflux will experience it weekly, and then, 20% of all adults, I'm sorry, 20% of all adults experience these kinds of symptoms weekly. 7 to 10% experience them daily. The typical symptoms are like heartburn, which is called pyrosis, 30 to 60 minutes after meals. And then you have regurgitation. Sometimes you have responses to PPI, sometimes you don't. And then failure to respond to PPIs is actually an important part of GERD we'll talk about. But when you do have a patient presenting with GERD, especially with dysphagia, that's something that should make you a little bit more concerned that something else is going on. For example, if you have new onset GERD after the age of 60, that's not pretty typical. If there's any evidence of a GI bleed or anemia, that's also atypical. Dysphagia or dynaphasia, unexplained weight loss, all of that makes you concerned that there's cancer, there's something else going on. So that's always in the back of your mind. You just don't want to rule out, oh, everyone has GERD, it's fine. Those are things to think about. Next. Medical management essentially depends on whether the symptoms are mild or they're severe, and what do you find on endoscopy. So in terms of medical management, there's a sort of step-up approach to GERD. You start with histamine blockers, H2 blockers, like famotidine, cimetidine. If it's persistent over 2 weeks, you initiate PPIs every day, like omeprazole. If that doesn't work, you go to BID PPIs. And then you reevaluate in 48 weeks. And patients should feel better. They should respond, right? And if they don't respond, you have to find out the reason for that. So when they don't respond, that's often an indication for surgery. That's one of the most frequent indications. There are some patients who are unable or unwilling to take daily medications, whether it's anatomical or surgical or whatever the reason may be. If the patient has sort of atypical symptoms that have been ruled out for any sort of more insidious causes like chest pain, asthma, chronic cough, hoarseness that aren't due to malignancy, you've done the workup and it's just a presentation of GERD that you feel, that may be an indication for anti-reflux surgery, severe esophagitis, or these patients with like really bad GERD who haven't responded, and you're worried that they will develop a stricture. That could mean an indication for reflux surgery, anti-reflux surgery. Patients with cancer, patients with high-grade dysplasia, portal hypertension, and obviously non-op candidates, those are patients who should not get anti-reflux surgery. We will talk about the actual surgery a little bit later, but in terms of the pre-op workup, you need to do an endoscopy. These are the options that you have, right? So endoscopy is very, very specific if you see the evidence of GERD on endoscopy, but it's not very sensitive. A lot of patients with symptoms will be negative on endoscopy, so about 50%, right? If you have a normal esophagus on endoscopy, you consider that uncomplicated GERD or non-erosive reflux disease. But it's important to rule out if the patient has erosive esophagitis, if the patient has strictures. GERD obviously predisposes to Barrett's, and so that's something you have to rule out. You want to make sure the patient doesn't have any cancer or a gastric outlet obstruction. All of these are things that you're thinking about in terms of, does this patient need anti-reflux procedure? There's a couple classifications of how bad the GERD is. We'll show a slide next just to sort of give you an example of that. There's the LA classification and the Savarino classification. The LA classification is more common. You can also do manometry, which we'll talk about a little bit later, to measure sphincter pressures in the upper esophagus, throughout the middle esophagus, lower esophagus. GERD is typically diagnosed if the lower esophageal sphincter pressure is less than 6. We talked about it earlier, normal is 15. So if it's less than 6, you're very, very high risk of having GERD. And so that's diagnosed, right? When you do the manometry in patients with a normal EGD, because you also want to find out if their GERD symptoms are related to a proximal motility disorder. The true gold standard of measuring GERD is essentially defined by the ambulatory pH monitor. We want to measure pH in all the different aspects of the esophagus. Unfortunately, they sort of live with a pH monitor in the nose for 24 hours. But this is really the confirmatory test. And then another sort of benefit of this is you can actually measure like the physiological response to treatment. In terms of diagnosis, you want a Demeester score greater than 14.72. That's the magic number that has shown up on practice questions. The other way that this pH monitoring score can be positive, if it's less than 4 for more than 5.5% of total time. But you can also measure how much, what percentage of time it's under 4 when the patient's upright versus when the patient's supine.
Hey, Peter.
Yeah.
You briefly kind of brushed by it on the previous slide, but you mentioned how a lot of the times we are referred for these cases because people want to be off PPIs, and it's true. I mean, a lot of gastroenterologists sometimes will just prescribe you PPIs forever. In fact, I have a lot of patients who are just chronically on it for their entire lives. What are those side effects of PPIs that we kind of have to be a little bit more aware of rather than prescribe them kind of like just water, you know?
Yeah, that's a huge consideration. So I'm sorry. Essentially, like PPIs, like the short-term side effects are like, like nausea, vomiting, things like that. But with patients on like PPIs for a long time are at risk for like fractures, they're at risk for C. diff. They can like develop like interstitial nephritis, things like that.
Correct. And I think especially with what my patients are telling me lately is a lot more. They're more really afraid of all the fractures, especially in the world of bariatrics, since we have a lot of patients with sleeves on PPIs for a long time. Sometimes we get, those patients are already malabsorbing calcium. So we're definitely more concerned about it. C. diff, yeah, we're seeing more of them. It's not as bad as before. I think as I would say the previous decade of bad C. diff when we had to do colectomy for people. But still, it's always a concern. So all these, even though it's PPIs are now almost like aspirin for some patients, I don't recommend it a lot for people to be on for a long time if they don't have to be.
Mm-hmm. Yeah. Thanks. This is a couple slides of the LA classification. I don't know if this is going to be on our app site, but essentially, I think I've seen some like obscure questions about this, but essentially it's grade A, B, C, and D, and it's graded by if there's mucosal breaks, and if those breaks sort of bridge on top of the mucosal folds, right? If it's a small break, it's less than 5 millimeters, it's grade A. It's greater than 5 millimeters, but it's within a mucosal fold, it's grade B. If it is above a mucosal fold and it's less than 75% circumference, it's grade C. If it goes all the way around, it's grade D. So surgical treatments of GERD. So essentially, I'm not sure what's going on. Okay, so fine. There's a couple of different approaches, but most often they are related to fundoplication, right? So this is where we wrap the fundus around the esophagus to prevent reflux material into the esophagus. So the classic one is the Nissen. It's a 360-degree wrap. There's also the toupee, the posterior. It's a posterior 270. A door can be an anterior 180 to 270. There's a Hill repair where you recreate the angle of His with a posterior gastropexy. And then if you don't want to do it transabdominal, you do a transthoracic one. That's called the Belzy, Mark IV. That, unfortunately, I haven't seen anything about, but I've seen this in toupees and doors. I haven't seen a Hill repair. Obviously, with the surgeries, there's a lot of potential pitfalls. Obviously, bleeding, you just around the right cruce, near the IVC, near the aorta on the left cruce. And those are obviously things you have to definitely be aware about when you're doing those stitches to sort of proximate the hiatus. The risk for short esophagus is real. One of the technically challenging things about these procedures is making sure you have enough length of the esophagus brought down into the abdomen, so that when you do your wrap, it doesn't just shove back up into the hiatus and then the patient complains of dysphagia. When you do these procedures, there is a risk for slippage, or there is a risk for herniation of your whole wrap to go into the chest, and that's something to be aware of. Obviously, if you are a little too aggressive and you take the wrong bite, it's a difficult dissection and it's really tough, you're at risk for perforating the esophagus. So those are all issues. Post-operatively, the most common complaint is dysphagia, right? It's typically from post-op edema, and it's supposed to resolve in a couple of weeks. And these patients are obviously very uncomfortable if it's immediately post-op. And if it continues to be like that, then there's something wrong. So you would start with endoscopy and consider reauthorization. Most of the time, the problem is usually that the wrap is too tight. That you've made a fundal application that's too tight, and that needs to be released. Another post-op problem is sort of gas float syndrome, where if it is too tight, the gas that accumulates in the stomach doesn't sort of exit out through the top of the esophagus, and then you feel like really bloated, and it's almost like an outlet obstruction of gas with a proximal blockage.
Let's ask team 4 here. What would you do when you have a short esophagus? You just can't get enough esophagus into the abdomen.
Do you know what it's called when the procedure to lengthen the esophagus? Do you kind of remember what it's? Collis gastroplasty. Can you hear me?
Yes, we can hear you.
We can hear you barely. How do you do it?
A Collis gastroplasty. So it's
Good.
where you basically take the kind of fundus of a piece of the fundus of the stomach off, and you're essentially kind of creating the proximal stomach as like a more of the esophagus, and then you make your wrap lower on the stomach and create a new lower esophageal sphincter. It's kind of
Good. Yeah, you essentially lengthen the esophagus by creating a neo-esophagus out of the stomach. Correct. Tuberalizing the stomach.
Unfortunately, I didn't put a picture of the Collis. I think if you haven't seen it before, pictures are just actually really clear to explain what's going on. So if you haven't seen it before, if you're an intern, you should take a look at the diagram. It's pretty helpful. Esophageal strictures is our sort of next topic, specifically the non-malignant strictures, because malignant esophageal strictures is a whole other topic that we won't get into today. But essentially, you two different classifications just based on the appearance. They could be smooth, they can be complex. The smooth ones are usually short, they're usually straight, and traversable with a scope, whereas the complex ones may be irregular, they have severe narrowing. These are usually associated with a hernia or a diverticula. If it's truly non-malignant, you've done your biopsies, you've done your workup, and it's not cancer, not eosinophilic esophagitis, there's a couple things that you can do, which is essentially dilation. You can dilate with like a push bougie under wire guidance and the fluoroscopy, or you can do a through the tube balloon dilator, where you do the endoscopy, you put the dilator sort of through the working channel, and then you sort of balloon up that structure. Oftentimes, within each procedure, you have multiple serial dilations, and the patient may require multiple trips to endoscopy to sort of get some kind of relief of these symptoms. And it's questionable how long lasting these interventions are. But it is better than living with it. Next topic is Barrett's esophagus. This is where you have metaplasia. Metaplasia is conversion of one cell type to another cell type That's different from dysplasia. So metaplasia is going where columnar epithelium replaces the stratified squamous epithelium. Okay. So you can visually it's from like the down up, right? Because this columnar epithelium is on the stomach side, and then it replaces the proximal esophageal epithelium. Risk factors for developing Barrett's includes GERD. Patients who are obese have a higher risk factor of developing Barrett's. If you have a family history, and smokers. Those are sort of the main categories. Depending on which study you look at and which longitudinal studies, you just essentially you have a risk of developing. If you have high-grade dysplasia in Barrett's, you have a 6% risk of progressing to cancer with every year. And so these patients really, really need to be monitored. You really like this is extremely it's like colonoscopy. It's very good preventative medicine to be able to like find these lesions and prevent development of cancer. But it is pretty challenging because Barrett's development of dysplasia can happen anywhere. It doesn't form like pops. So you have to do like 4-quadrant biopsies every 1 centimeter for in this esophagus, so that every place that you see Barrett's. And it's if you've done your endoscopy rotation, you know that this can be quite an ordeal, and it's risky. It can cause perforation, it can cause bleeding. It's not so easy. In terms of the histological grades of Barrett's, there's different sort of grades. If you do a biopsy, it's negative, or it's indefinitive, or it's low grade. That's considered sort of uncomplicated Barrett's. If you have high-grade dysplasia or you have adenocarcinoma, then it becomes sort of a different story. Essentially, you can define Barrett's as when any length of the columnar epithelium is seen endoscopically within the stomach. Right? It's easy for me to explain when I've done my endoscopy rotation. I've seen it, but essentially, when you see that Z line come up where the Z line isn't supposed to be, that's essentially Barrett's. You can put it that way, and you need to confirm it on biopsy. So that's how you diagnose Barrett's. The way you surveil it depends on the type of dysplasia you have, right? So if you have no dysplasia, you do your endoscopy every 3 to 5 years. If you have low-grade dysplasia confirmed on biopsy, you do your endoscopies every 6 to 12 months. And if you have high-grade dysplasia, it's every 3 months. It's quite an ordeal. It's a lot to monitor. But these patients need it because they have such a high risk of developing cancer. Let's say you get your endoscopy, you find you have Barrett's. What can you do about it? Right. So there's a couple of different endoscopic treatments. You have ablations. You have a bunch of different types of ablations: thermal, cryo, radiofrequency ablations. Those I'm sure people who are more interested know the difference between all those. I didn't bother to look up the differences. There's mucosal resection. You can do endoscopic mucosal resection, EMR. In order to do that, you do need to do an EUS first, right? You need to be able to look at the lymph nodes, make sure that there's no lymph nodes involved. It's not, if the Barrett's isn't sort of hiding, masking underlying malignancy. And then if that's the case, that the EUS is negative, then you can be able to do a mucosal resection of small non-ulcerated lesions, or just lesions, just areas of high-grade dysplasia. So ideally, you can see on this diagram to the right how low the EMR goes. So I'm not going through the muscle areas. We're trying not to perforate the esophagus, obviously, but it goes deeper than the muscularis mucosa, which is the sort of the depth of just ablation. So EMR is able to go a little bit deeper. There are apparently places in Japan where you can sort of skip taking all of the epithelium and mucosa and just like make a tunnel and just do submucosal resection, but that's really only done in Japan. I don't think that's really, maybe some people are doing in the States, but that's not sort of a common thing. It's just an interesting point. So let's do team 3 to go over this slide for review. Ready?
Can you hear us?
Yes, thank you.
So pathophysiology of GERD due to lower esophageal sphincter dysfunction.
Yes, great. And confidence, sure.
And then surgical indications of GERD could be chronic GERD despite prolonged PPI use.
Not just prolonged PPI use, but what about that PPI use?
You're still having symptoms.
Exactly, right? So refractory failure of medical treatment. And then there's other complications that define it being refractory beyond failure of medical treatment. I briefly mentioned that. Can you think of those complications?
So complications due to PPIs, like fractures, fractures.
No.
Or
not that. In terms of determining sort of the result of GERD in the esophagus because the PPIs didn't work. So like I'm going for stricture, bleeding, esophagitis, like stuff like the actual, like the sequela of the actual GERD, okay? And so if you have those symptoms and you're on PPIs, that can be an indication for surgery.
And so metaplasia of squamous epithelium to columnar epithelium.
Rates?
So uncomplicated Barrett's can be, the EGD timeline would be every 3 to 5 years.
And you do it for life. Okay, so you measure Barrett's for life. I forgot to mention that one. That's pretty important. And then last is
high-grade dysplasia. Treat it with it's like repeated EGDs every 3 to 5 months. Or
that's surveillance, not treatment.
Oh, sorry, ablation.
Yeah, good. Obviously, you can always take out the esophagus, but you can do endoscopic ablation and sort of submucosal resections. Right? Less extreme than the esophagus. Right. We're going to continue and keep moving forward and talk about peristalsis because we're going to go to motility disorders, right? So just remember from medical school, there's three different types of peristalsis. Primary peristalsis is essentially when you're actually swallowing and you're actually trying to swallow a food bolus. And so your pharynx from your pharynx down to your stomach, you have a peristaltic wave that you voluntarily initiate, right? It starts in the swallowing center of the brain, your upper esophageal sphincter relaxes, and the contraction initiates, then the lower esophageal sphincter relaxes, so the food sort of progresses downwards. Secondary peristalsis is a little bit different. It's when the food, if your food doesn't, your primary swallow doesn't push the bolus all the way down, and so the esophagus has sort of the secondary propagating wave to sort of push whatever food didn't go down in the first time. Tertiary peristalsis is not truly peristalsis. There's sort of like disorganized movements of the esophagus because it's not really working. It's seen in unfortunately elderly patients and those with motility disorders, which is what we're going to talk about next. So this is sort of a diagram of primary peristalsis, and then the way we can actually measure that is with this diagram on the right, which is depicting manometry. Of note, remember that there's 3 different points of physiological constriction, where basically for me, I think about this is where my NG tubes get stuck, or could get stuck, right? One is at the joining of the laryngeal pharynx to the esophagus, where the aortic arch crosses, and then where you have the esophageal hiatus and you have like a hiatal hernia there, you get stuck there. So there's a bunch of ways that you perform esophageal function testing if you're concerned for a motility disorder. There's manometry, there's high resolution impedance, you have relaxing pressures, you have pH monitoring. All of these tests are to evaluate for the lower esophageal sphincter to see how much pressure is there. You're looking at the function of the esophagus, what the peristaltic waves look like, and then trying to evaluate for the crura, right, to see if there's any hiatal hernia. So this is a manometry. Essentially, you put a wire or a tube down that has like the pressure sensors, and then it's delineated by length, so you can see at what length in the esophagus has what sort of pressure reading when the patient is swallowing, So that's essentially the idea of it. And so they're read out like this because you can see sort of this y-axis has two lines. One is centimeters from the incisors or centimeters from where you're measuring. You measure, and then you measure the pressure gradients over time, right? So, oh, up at 5 centimeters, that's when the patient's swallowing, right? So that's probably at the upper esophageal. Then you go down, that's peristalsis. Then you come down, it's the lower esophageal sphincter, and then relaxes, that kind of thing, right? And so this, again, it's another depiction of measuring a bunch of these. And this diagram shows you sort of 5 different pressure sensors in this area, and you can measure the pressure waves in those 5. You can measure sort of the amplitude of change. And so this is a example of a pressure reading 180 millimeters of mercury at the lower esophageal sphincter. And this is diagnostic for nutcracker esophagus. But you can also have a lot more pressure sensors. So the new technology, so instead of reading those 5 at a time, you can read like 36 at a time, and then you can, instead of depicting it through like these actual waves, you depict it with color, and so you have sort of this. You may see this in textbooks, essentially depiction on the right side, where it's blue if it's low pressure, and then it changes up to red when it's high pressure. So this is essentially primary peristalsis. This is someone who's swallowing a bolus of food, right? So over time, it starts up here, and then the pressure migrates down, 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 down. So that's sort of the idea of what a normal manometry looks like. You could also add on impedance studies to this, right? So impedance studies, essentially, you're looking at electrical conductivity in the esophagus, right? Not pressure. Air versus liquid versus mucosa all have different impedances. So you can actually look at in the esophagus at this length, at this time, what's the actual impedance, what's the content, not just the pressure of the esophagus. Ideally, impedance sort of decreases as you go from proximal to distal, right? That, which makes sense, that as you go proximally in the esophagus into the stomach, you should have more fluid, right? Instead of air or instead of mucosa, because that's where your stomach content is. But if you see the reverse of that, if you see fluid coming up proximally, then that can be diagnostic for reflux, right? So that, if you think of it that way, hopefully that makes sense. This is essentially what the readings look like. Not going to be tested on this. Another way to sort of measure esophageal motility is through a barium swallow. It's just, we've probably all seen this, like upper GIs, where we evaluate the basic anatomy and swallowing function. You can use thin barium, you can use thick barium. Thin barium is really good at distinguishing outlines and distinguishing the anatomy. When it's thick barium, it adheres a little bit more to the mucosa, and can actually be mixed with like soft food. So if you actually look at a swallowing mechanism. So that's why you would use one of the other. Another one is video fluoroscopy. And obviously, you can do single pictures with an upper GI, but fluoro, you can actually see in real time. You can see the swallowing mechanism. It seems to make sense. I don't think there's that much to talk about, except that they typically use like a thick barium. Yeah. So these are the esophageal motility disorders. There's a bunch of them. There's achalasia, diffuse esophageal spasm. We won't be able to go into all of these. We'll talk mostly about achalasia because it's best studied and it shows up a lot in practice questions. There's primary esophageal motilities, which is where it's an intrinsic problem with the esophagus. And there's obviously secondary motility disorders where motility is due to some extrinsic thing, right? Esophagitis causing an issue, scleroderma causing an issue, stroke, Parkinson's, that kind of idea, right? So you can divide it between primary and secondary, or you can sort of divide it by the anatomy of where the motility is occurring, right? So upper esophageal versus lower esophageal motility disorders manifest differently. The symptoms are different, right? Upper esophageal disorders are usually with upper dysphagia within seconds of swelling, right? Which makes sense because that's where our striated muscle, that's where our voluntary upper esophageal sphincter is working. If you have dysmotility there, then you can't functionally initiate that swallow. So you have coughing, you have choking, you have regurg. To diagnose this, you can do this, your little fluoroscopy, your swallows, modified barium swallows, In these patients, you have to do an EGD. You want to rule out Sanker's. You want to rule out esophageal cancer. With the lower esophageal motility disorders, the other tests, you do a lot of the similar tests, barium, esophagram. These ones benefit more from manometry and pH testing because if it's lower esophageal, then you're thinking of sort of a different spectrum of disorders. Is it reflux, hiatal hernias? These patients still also need an EGD if you're suspecting something like achalasia. This one, there isn't like good, strong evidence to suggest that all of these patients need EGDs. When we're talking about achalasia, there are two physiological disorders to consider. One is that if there's a failure of the lower esophageal sphincter to relax, so you see high pressures on measurement, and you have resistance of flow into the stomach, and then you have loss of peristalsis in the distal 2/3. And those are two different things, right? There's lower esophageal sphincter pressure, and there's loss of peristalsis. Pathophysiology is thought to be loss of ganglionic cells in the myenteric plexus. I've seen this sort of in flashcards, but not necessarily practice questions. Not really known what the cause is truly, but they suspect there's some autoimmune components to it because they found like antibodies to the myenteric neurons. So it's definitely not going to be tested. These patients usually present with dysphagia, mostly to solids and sometimes liquids too. Some present with chest pain. You do have heartburn in some patients with achalasia. Weight loss, mostly from like, fear of eating because it's so uncomfortable. And then nocturnal cough and recurrent aspiration is another way these patients can present. To diagnose them, if you want to use a plain film, you can. Really good ones, I guess, will show air fluid levels and a widened mediastinum. These patients, because if you think about the mechanism, makes sense. An absent gastric bubble because the lower esophageal sphincter is at a higher pressure, stuff's not getting through. So the stomach doesn't fill with gas. You may have pulmonary infiltrates if you have a lot of regurg and you have some element of aspiration in those. Barium esophagram is like the gold standard way to diagnose achalasia, and you all remember sort of the bird's beak picture that you remember from med school. Endoscopy is extremely important in these patients. You want to rule out tumors, especially in patients over 60. And then manometry findings. This is often a tested question. What are the findings of manometry in achalasia? They ask it like 5, 6, 10 different ways. So it's absent peristalsis, decreased LES relaxation, and increased resting pressure of the LES. So not only does the lower esophageal sphincter have increased pressure, but doesn't relax as much. Again, that's a different function from absent peristalsis. So that's both that you see in achalasia. This is the chest X-ray. I'm just saying. Bird's beak picture. Memorize this picture. If you ever get the question on your absence. I don't think there's not much to talk about here. This is the actual what you would see on manometry, right? You initiate a swallow up here, and then no peristalsis, no peristalsis, no peristalsis, and then a bunch of high pressure below the esophageal sphincter. Right? That takes a long time and it doesn't really relax. So you have this baseline elevated pressure of the lower esophageal sphincter, and then when that sort of bolus arrives, just through gravity, then you have a higher pressure and it doesn't relax. There are 3 different types of achalasia. I've never seen a practice question on this, but we'll talk about it briefly. Type 1 is where the esophageal body has minimal contractility. Type 2 is when you don't have peristalsis, but you every once in a while the whole esophagus like sort of squeezes up. And then type 3 is sort of the spastic contractions of just the distal esophagus. Apparently these are all considered achalasia. So the way you treat it is essentially try to reduce the lower esophageal sphincter pressure and increase the emptying, right? Because if you understand the mechanism, that's how we're going to treat it. And so a lot of it is medical, nitrates, calcium channel blockers. You get great response initially, like 70%, but after a year, a lot of those patients stop responding, right? That's called tachyphylaxis. So that's important thing to consider. And then obviously nitrates are not benign either. This can cause a lot of headaches. Patients don't like nitrates. You can do Botox. Botox has also, again, very, very good initial response, but long-term results aren't perfect, but less than 60%. So still think that's pretty good. Pneumatic dilation of the lower esophageal sphincter is another way to do it. Again, good initial response, has better sort of drop off in terms of long-term response, but these patients usually require redilation. Not necessarily the most benign thing, because you can perforate these patients when you're trying to do that balloon dilation. So you have to be aware of that. And also, like, you're at risk of developing, these patients develop like worse reflux. Surgically, though, the one with a really good initial response and the best long-term outcome is surgery. It's a Heller myotomy. These patients also do develop reflux, and up to 50% of them later on. So, that is the concern, but in terms of treating the achalasia, it's very effective. So the types of achalasia does sort of guide your treatment in terms of what intervention you do. I don't know if this is actually going to be tested, like, oh, this patient has type 2 achalasia. Are you going to give them XYZ? I think the outside's not going to get that far, but sort of for our own edification, that's something to think about. So when you need to do a procedure for achalasia, you do your Heller myotomy, right? You essentially do a myotomy of these longitudinal mucosal muscular cells, and then you need to do a fundoplication in addition to it. Sometimes these patients have common hiatal hernia, so you can do a cruciate repair, but not all the time. But in terms of when you do that myotomy, you want to be able to sort of protect that. So you can do an anterior door, or you can do like a posterior, like 180. I haven't seen that combination before, but technically that's possible. If you want to do a posterior myotomy and then a posterior wrap, this is essentially what it looks like sort of at the end of the procedure. If you had time to look at it. You can also do this endoscopic treatments. This is sort of becoming a hot new thing. The results actually are apparently pretty promising if you look at the data, where you essentially do it endoscopically, you create a flap in the mucosa, tunnel down to the lower esophageal sphincter. You perform a myotomy there, just on one side, and then you close up. Apparently, this is well tolerated, but it's obviously very technically challenging. You need the right people, you need the right experience to do this, and so the people who try it not necessarily have good outcomes. Type 3 achalasia apparently responds to this really well. This is what it actually looks like if you're interested. It looks kind of gross. So that was achalasia. All these other ones are like diffuse esophageal spasm, nutcracker esophagus, hypermotility, jackhammer esophagus. All of these can sort of be lumped under the category of spastic motility disorders. So with spastic motility disorders, these patients usually present around the age 40. It affects females more than males, and it presents with dysphagia to both solids and liquids in up to 60% of patients. It can be intermittent, non-progressive. So a lot of oftentimes in patients with dysphagia, patients later on are found to have use of esophageal spasm. You can also present with chest pain, pyrosis. And the issue with these patients is that their manometry readings are usually kind of off compared to the symptomatology. So that's sort of one of the clues to suggest that you have some kind of motility disorder. So diffuse esophageal spasm, this is characterized by uncoordinated contractions of the esophagus. It's pretty rare. We don't really know the pathophysiology. It's thought to be related to like nitric oxide production, but you can see sort of these characteristic variant pictures on this right-hand side. When you do manometry for these patients, essentially it just looks like strange contractions that are simultaneous. So you see like these long vertical segments of contraction that's not sort of in this progressive line that you would expect in like a normal swallow setting. Nutcracker esophagus is apparently it's a variant of diffuse esophageal spasm. I've forgotten about that. but it's where you have like specific high pressure peristaltic contractions, where in over 10 swallows, you have an average pressure of over 180 millimeters of mercury. And these can last for like 6 seconds. So it's like a really high pressure at one specific point, which hence the name. Right? The pathophysiology is also still not well understood. They thought it's related to nitric oxide production. There's apparently some link to good. And the manometry that you see in a couple of areas where the pressure goes up to 180, 200 millimeters of mercury in those areas, and it squeezes and stuff. There's a bunch of other motility disorders that I actually am just going to skip through because we are going to progress to the last topic, which is hiatal hernias, which is really important to talk about. In terms of treatment, you want to aim for trying to relax these muscles as well as symptom relief. So obviously start with PPIs. Patients are usually started on a PPI first. You can use the phosphodiesterase inhibitor, which is like sildenafil. These can be smooth muscle relaxants that can lower the LES pressures. Botox we talked about sort of in achalasia. So we all know the mechanism of that where it paralyzes the muscle. Antidepressants apparently have been used with some variability of success, especially in patients with IBS. There aren't any formal trials, but apparently it's pretty good. And then diet. Hopefully that's like the easiest, cheapest intervention that they can sort of have some kind of diet relief. If you do need to do surgical treatment, this is usually in extreme cases where if you have an entire segment of esophagus, you do a myotomy along the whole length, and you have to obviously go through the chest to do that. And if you want to take up the esophagus because it's kind of causing problems, you theoretically can, but I think that's kind of irrelevant. So can we go to let's see, does Surgeon have their phone working yet? Oh no, we'll go to Elmhurst.
Uncoordinated contraction. Yeah,
diffuse esophageal spasm.
Okay.
Achalasia. And then nutcracker esophagus.
So which
upper.
Okay, perfect.
And then lower.
Perfect. Good job. All right, so hiatal hernias. This is the last topic, and we'll get out of here. First described by Bowditch in 1843, he did a postmortem and saw the giant hiatal hernia, where it's defined as a protrusion of any abdominal structure other than the esophagus into the thoracic cavity through a widening of the diaphragmatic hiatus. Right? Prevalence is actually much higher than you expect, and even though it's prevalent, it may not be even symptomatic, which is probably why. It's depends on how old you are. It's obviously more common in older patients because it's thought to be related to like laxity of the phrenoesophageal membrane. That the more lax it gets, the more likely you are to sort of herniate up there. Most of them are sliding hernias. True paraesophageal hernias is only really like 5%. These are the different types. So type 1, type 2, type 3, type 4 will be tested. So type 1 is your sliding hernia, where your GE junction slides up into the thoracic cavity, where the Z line is above where you should expect where the crura is. A type 2 is essentially where you have the GE junction is okay, but you have sort of part of the fundus sort of sneaking itself up there past the hiatus. Type 3 has the GE junction and part of the fundus up into the hiatus, and the type 4 is the stomach and another organ going up into the thoracic cavity. So this is type 1. It's the most common. The GE junction is above the diaphragm, and we talked about that. It usually occurs in patients with an increased abdominal pressure. You obviously have GERD because your Z line and your GE junction are in the right place. But oftentimes these are asymptomatic. These are found incidentally. You don't need to treat. A type 2 is is a true paraesophageal hernia, right, where you have stomach herniating around the esophagus, right? In these cases, the GE junction is below the diaphragm. It's due to anterior weakness, the esophageal ligament, and weakening of the pleural peritoneal membrane, and then the esophageal hiatus actually dilates, is enlarged, right? And that sort of accommodates the stomach. Apparently, the GE junction is below the diaphragm and it's held in place from the posterior lateral attachments. That's why it doesn't herniate up. But the contralateral side is a little more lax on sort of typically like the left cruce, and that's where you get the hernia. Type 3 is more common than the type 2, where it's sort of mixed, where the GE junction is above the diaphragm, and you have part of the stomach goes along there as well. A type 4, where another visceral organ sort of herniates into the diaphragm, above the diaphragm as well. Colon is the most common. And then it's usually due to increased abdominal pressure, you have a large hiatal defect, you have laxity of these ligaments. And again, obviously, because the stomach is up there, the GE junction will fit you. So when you're thinking about a patient who has a hiatal hernia, you want to get an EGD. These are very, very accurate. And if you do a retroflex in the esophagus, which I've seen once, you can see where the Z line is, and so you look where the Z line is, you look where the G junction is, and maybe you could find type 1 there. Chest X-ray, maybe you can see some mediastinal soft tissue, maybe some air fluid levels, but barium esophagram is going to work really well. Manometry, plus or minus, but CT scan obviously is how we usually find these. This is what a barium esophagram looks like. When you have this hiatal hernia, you see the esophagus come in, and then you see it, the herniated stomach sort of filling up in contrast. This is sort of another good view. So, when do you repair these patients? So you don't repair the asymptomatic ones unless they're really large and they're like young and healthy, and it is actually if it's asymptomatic, you don't do it unless it's large and they're young and healthy. You can decide what kind of approach you want to do versus abdominal or thoracic. Most of the time that we're seeing in general surgery is the abdominal approach, but thoracic is an option. The thoracic approaches usually require a longer abdominal stay, but it is an important sort of option when patient has sort of a hostile belly. They've had bypasses before, they've had like perforated bowel before. Like, you don't want to go into the belly and do these repairs and compromise repairs. So you may consider a thoracic repair. We do open versus minimally invasive. Minimally invasive has really good outcomes. So it's something that I'm sure all of us will see on our residency. Key steps for doing these procedures: you have to reduce the herniated contact. You have to excise the sac from the posterior knee side. I had forgotten about this step. We actually did a case with Messer yesterday, and that was the step that took a little bit of time. You got to mobilize the distal esophagus to have at least 3 centimeters within the abdomen. You want to make sure there's a tension-free closure of the esophageal hiatus. And then you want to perform an anti-reflux procedure. That is a different procedure from actually repairing the hiatal hernia, but it's something to consider. And then you can also do sort of a gastropexy, whether or not that's part of the reflux procedure or not. When you think about laparoscopic repairs, there's obviously a lot of advantages that we sort of talked about: shorter hospital stay, better recovery, better quality of life. You can really get good visualization of the hiatus. You get your penrose around the esophagus, you pull it left and right, you can actually see sort of circumferentially around it. The 30-day mortality is pretty low, so there's really good outcomes. The issues, though, is you can have pneumonia, you can have a pulmonary embolism, you can tear the vagus nerve, you can have a pneumothorax, and you try to dissect up in that sacs, and you get into pleural space because all it looks like sort of stuck tissue. You dissect in the wrong way, dissect too deep, and your risk for complications are higher if you're old, if it's an emergency surgery, or you have a high ASA class. These are just some pictures of what you should see, hopefully laparoscopic, where you literally see this giant diaphragmatic hernia, you see this huge hiatus. The idea is that you bring that together, you do a couple stitches, and hopefully they come together. However, it's not necessarily easy. This is a really wide gap. You try to put a stitch in one, you stitch in the other, and you pull, you just tear through the muscle. It's too far apart. If it's too large. You try to literally bring it together. So one move you can do is you can put a relaxing incision on the right cruise and sort of, obviously avoiding the IVC, separate that muscle a little bit and try to bring the right cruise over to the left ear. And then you close with stitches, and some people will advocate putting a mesh on top, which we'll talk about. So outcomes wise, laparoscopic is really good. You have 80-90% success. You have, we will talk about this as well. You do have some element of radiographic recurrence. So you get patient gets worked up with imaging later on. You see, oh no, they have a hiatal hernia again. But do they clinically actually have symptoms of a hiatal? That's the question. These, if they do have recurrence, can they usually be controlled with medications? And typically they can. It's rare, but it happens that patients need to be re-ups. Let's see, with the laparoscopic technique, the radiographic recurrence is high, but clinical recurrence is only 10%. And the thought is that when you are able to do more esophageal lengthening, you can get a lower chance of recurrence. So you can bring the GE junction like 1 centimeter into the abdomen, but that's not as good as being sort of 3 or 4. But it may not be easy to get that extra length. A couple centimeters is not trivial. You can do a transthoracic technique. This is very, very low clinical recurrence rate. So at least the rate that required reoperation. Oh, call us.
Peter, I'll make a quick. I'm glad you're talking about this because I think one of the key points you can learn from the thoracic literature is that one of the reasons why they have such, I think, better recurrence rates when they approach from the chest is that they do routine cholecystoplasties or routine lengthening. So, all these cases, unfortunately, have a tendency to just kind of push right back in the chest. That's why you have such a high radiographic recurrence. So, I do tend, if I have cases where I'm just not worried, I'm just not sure that things are going to stay down, then lengthening, I think, gives you a lot more give in that matter. And the thoracic literature shows it. I think the thoracic guys like to do the lengthening because it's just, you kind of have to, to approach the chest and to get down into the stomach, you kind of have to lengthen the esophagus no matter what. So I think when it's, needed to be done routinely from the thoracic approach and has good results that way, then we can kind of simulate that from the laparoscopic side.
Right. Yeah. I need to look at how they do the thoracic approach because I'm not so familiar with that, but I'll have to look into that. That's interesting. This is kind of a depiction of a cholecystoplasty. There are esophageal lengthening procedures where this is the angle of his down here. This is, I guess, an open way of doing it. I've only seen it done laparoscopically, where essentially you do lengthen the esophagus by cutting down, stapling down on the angle of his, and allow yourself to have a better wrap. One thing that you can do as well is you can do a vagotomy. Sometimes it's the nerve itself that's holding you up. Then you sort of divide the nerve, then you have a little bit more length. That's always is an option, but obviously you have to be aware that you can lead to delayed gastric emptying. But we used to do vagotomies all the time for acid secretion in patients to find. Talking about closing large defects, we talked about doing a relaxing incision to perform a tension-free closure. Some people back in the day advocated, if you do close it under tension, you reinforce it with a mesh. And then you can do sort of a C configuration, you can do a U configuration. We used to think that a C configuration of mesh covers anterior and posterior, so it may have better results. And we always use a biologic mesh because synthetic mesh is at risk of sort of eroding into the esophageal fluid. Whereas a biologic mesh, because it's resorbable, it dissolves, you don't have that risk. Let's see. That is the end of my slides for now. For the didactic portion, we have Journal Club. So let's do like a 5-minute break. My watch says 8:33, so let's come back at 8:35, and then we'll screen through this Journal Club. Unless people really just want to crank it out and just be done.